I'll give you a little background in sort of what's been going on in weight medications and why you see it so much in the news. We've had Oprah posting recently about how she's had a successful weight program using one of the GLP-1s. So let's start with that. GLP-1, what does that mean? So a GLP-1 is a weight medication that works on the GLP-1 receptor. So it's a category of drugs. So it relates to words you may be familiar with: Ozempic, Wegovy, Mounjaro. The generic names would be tirzepatide or semaglutide. These are all GLP-1s. And then the latest one to hit the market is Zepbound, which is really kind of a repackaged Mounjaro. So I would look and talk about Zepbound and Mounjaro interchangeably. They're both tirzepatide. The Mounjaro was actually, that formulation was studied in persons with diabetes, and then Zepbound was repackaged. It's also the same tirzepatide, but it was actually studied and actually approved independently for weight loss for persons that don't have diabetes. The exciting thing about Zepbound hitting the market recently was that it actually was studied quite a bit in women who didn't have diabetes, so they were using exclusively for obesity or being overweight with some cardiovascular or other health risk factors. So definitely proven safe in this group, but also hugely efficacious. The other exciting things about Zepbound hitting the market is that it provided another manufacturer making these drugs. We've been experiencing shortages. So even in patients that we have where we prescribe the medications, in some pharmacies, in some regions, they've had shortages that have delayed people starting for several weeks to even months. So just having another drug being manufactured and helping meet the clinical need is exciting. They also came out with a coupon program. So last year when these medications, all the excitement was about we finally have something that works in weight loss. But they weren't yet on insurance formularies. So if we looked at the beginning of last year, only about 20% of insurance plans covered these medications. Right now, for many parts of the country, about half of insurance plans cover these medications. So what Zepbound has is a coupon program so that if your insurance doesn't yet have it on formulary, and I say yet because, as I mentioned, beginning of last year we had 20% of plans that covered them. Now we have about half, so it's rapidly moving. So even if your insurance plan doesn't cover them today, they may cover them 3 months from now, they may cover them 6 months from now. So I would continue to stay on top of that. Most of us get our insurance through our employers, so look at our employer option plans. Also, it's fairly common that employers offer multiple plans, so you can look and see ahead of time at open enrollment which of the plans may cover it. So sometimes, though, at employers, there are none of the plans offer them as an option. It happens, it's not uncommon. So Zepbound came out with a program that says if your insurance doesn't cover it, instead of charging you the $1,200 to $1,500 a month cost, they will actually give it to you with a coupon for $550 a month. So it's still a big hit to the pocketbook, but certainly makes it more reachable to more people than the higher price. So the coupon program is available even if your insurance doesn't cover it. So that is the cash pay price with coupon. I swear I don't work for Lillian. I'm not a Zepbound rep, but these are some of the questions I'm hearing from patients, so I wanted to share that with you. So GLP-1s are a category of drug that include Ozempic, Wegovy, Mounjaro, Zepbound. It also includes, there's an oral one, Rybelsus. All these other ones are injectables that I've mentioned. It is a relatively new category of drugs, but I want to be clear that they're not, it's not entirely new. These drugs have been used in patients with diabetes really since 2015, and then the studies for that backdate even 10, 15 years prior. So we've been using these drugs in humans for a couple decades. Now in mass, for diabetes, since 2015, and then for weight loss, what they noticed then was those persons were experiencing much weight loss, so they studied it just for weight loss and showed massive efficacy. So for the semaglutides, which is one of the GLP-1s, that's Ozempic, Wegovy, they actually showed that first. So Wegovy got all the news because they were the first one actually to be approved for weight loss. And now Zepbound has been also approved independently for weight loss. So we're looking to see both of those added to more and more insurance formularies and accessible to women. I know there's lots of questions coming in, so keep your comments here. I'm trying to answer some of the common questions that we experience at Midi. You know, the basic one is, should I take these medications, right? So I do think they are wonderful adjuncts to lifestyle readjustments that we need at midlife. So in midlife, we reach our peak weights, very normal. It's very common for women to gain weight in midlife. So we see some women who have had a lifelong battle with weight. We also see other women who are coming in with a new battle with weight. We want to make it not a battle. We do want you to help achieve your best health, because other things that happen in midlife is as our hormones decrease, our whole metabolism changes. We know that cholesterol goes up. We know that our insulin sensitivity worsens, so our ability to process sugar changes. We know that we start to gain weight centrally, which means sort of our waist, people call it menobelly, so we get menopause. And that actually contributes to central weight gain. Central weight gain, we know, is actually a poor predictor of health. So if you have sort of evenly distributed weight versus someone who gains it centrally, that central weight gain is actually a worse predictor of health than overall weight, right? So these are things we want to pay attention to, because cardiovascular disease is the biggest killer of women. So we want to actually mitigate any cardiovascular risk factors. So some of it is addressing our central weight gain. So other common questions we get at Midi. So for women who are obese, so that means your BMI is above 30. So what is the BMI? BMI, you can calculate it. There is a calculator on the internet where you just put in your height and weight. So if your BMI is above 30, you are classified as being obese. If you have a BMI 27 to 30, that means you are overweight. But if you have other cardiovascular risk factors, you also would qualify for these medications, because they do help decrease your cardiovascular risks. We've had another exciting study came out this year that showed a 20% decrease in cardiovascular events in persons on these medications. This is massive. That was 20% reduction in 2 years. As we study people longer and they're on it, we hope to see even bigger reductions with time. So we know that obesity is an independent risk factor for cardiovascular events, so it can help mitigate these. So if your BMI is above 30, generally your insurance will pay for it if it's on their formulary. If it's between 27 and 30 and you have another cardiovascular risk factor, they also often cover it. There are people that are overweight and have cardiovascular risk factors where their BMI might be slightly below. So one question is, can these people benefit from medication-assisted weight loss? Now, I'm again using the word medication-assisted weight loss for a lot of reasons. Medication-assisted means that even in all these studies with all these medications, they are inclusive of and supportive of doing it alongside lifestyles that also support best health and best weight management. So that largely means diet and exercise. So these medications, many of them actually help improve calorie-restricted diet in that it decreases your appetite. So the GLP-1s, for example, will actually act on receptors in your brain that tell you you are full. So you will eat a more modest portion and you will feel very full. And it actually helps support this healthier diet. Now, let's talk about exercise. So whenever we lose weight, whether it be from just our own calorie restriction, whether it be from medications, or whether it be from surgery, we lose muscle mass. So when you lose weight, you are going to lose muscle mass. If we have surgery, like if we have obesity surgery and you get really rapid weight loss, 40% of weight loss is actually from muscle. If we're doing a slow, just calorie restriction, not medication assisted, about 10% of our weight loss is from muscle loss. And then if we do these GLP-1s, these newer meds, what we're seeing is about 20% of the weight that we lose is muscle. We don't want that. We want you to have muscle, right? We are in midlife. We want you to go into our later stages of life without being frail. We want to be strong. We want to be robust. We want to age well. We want to be healthy. We know we need muscle mass to retain bone health. We don't want to have fractures. So it's important, no matter how you're approaching weight loss, that you actually incorporate movement and exercise, because you do want to take efforts to actually maintain muscle mass and decrease your chances of being more frail, decreases your chances of fracture, and actually overall be healthy. We also know exercise has a lot of other health benefits. Like if you, there's a 30% reduction in breast cancer incidence for women that actually exercise more than 3 times a week. So lots of benefits of exercise. Exercise also is not just about the calorie burn. So exercise does calorie burn a bit. But really what it does is it actually helps our insulin sensitivity. So it actually also helps our cells use the energy that we do ingest or eat. So it actually helps our insulin sensitivity, which helps modify our appetite and helps our efficiency. So it's not, exercise helps us in many ways. It also helps us sleep better. Sleep is an important way to help with weight management. We know that if people don't sleep well, they actually gain weight. Counterintuitive, because people think they're up burning calories by being up at night, but you're actually gaining weight, because what happens in the day is you're more sluggish. You actually reach for more empty carbs, tend to eat more to have energy. So good sleep is a good component of a great sleep management program. I like all the waves. I'm trying to read the questions as I go. So another common question that I get at Midi is, I just want to lose 5 to 10 pounds to feel myself. That's my goal weight. And often the goal weight is very reasonable. It's in a healthy range. They want 5 to 10 pound weight loss. Can I take a medication just for a couple weeks to lose it and then get back? Well, you might be disappointed with the answer, but the newer medications that I've been talking about much of today really are studied for long-term use, right? So there's a titration period up, and then you stay on it, and then we know that if you come off them, that many people experience some of the weight gain back. So they're really intended for larger amounts of weight, to support larger amounts of weight loss, and truly people in the obese or pre-obese categories. For 5 to 10 pound weight loss, there's still a lot you can do. There are some medications that can be reasonable for this. Metformin is one. It's a drug decades old. We've used it a long time for diabetes. It also helps with insulin sensitivity. So if you seem to have predictors of poor insulin sensitivity, maybe you're in the 30% of us that actually have prediabetes, which means our blood sugars float a little bit high. But it also has been shown to help modify our average blood glucose, which we know is helpful in many ways. As I mentioned before, it can be helpful in cellular repair and even cancer prevention. So a lot of people in the anti-aging community use metformin daily. So you can be eligible for metformin, which has been shown to assist with modest weight loss in some people. But there are also many other pillars to weight loss, right? So we talk about really 6 pillars of weight management, really that help you get into a healthy weight. One is we look at your hormones, right? As I mentioned before, when our hormones change, it changes our insulin sensitivity, it changes our cholesterol metabolism, people's cholesterol goes up, it changes us to gain centrally. So can you benefit from hormone management? So that's one pillar. Second pillar, movement and exercise. If you're going to lose weight, you need to exercise. It's so good for you. It helps some of the other pillars. It helps with sleep. It helps with stress. So if you're highly stressed, it can lead to poor eating habits because we have what's called stressful eating. So hormones, movement and exercise. And then nutrition. Everything is about nutrition. So even if you take the medications or don't take the medications, generally when you're looking at diet, you're looking at calorie restriction, right? So then what you eat really matters, because you need to feed your bones, you need to feed your skin, you need to feed your hair health, like you need to feed everything with the essential vitamins and minerals. So when you do calorie restriction, what you eat is super important. The other thing to realize in midlife is our metabolism do change, right? So our insulin sensitivity worsens, our cholesterol metabolism worsens. So we have to really start changing our diet to support our best heart health. So you'll see increase in, we need more omega-3s for our heart health. We need sort of less simple carbs. We can do complex carbs, but we need sort of better glycemic control foods. Okay, so first 3 pillars: hormones, exercise, nutrition. Fourth one I mentioned earlier, sleep. Good sleep actually is associated with good weight management. 60% of us have poor sleep in midlife for a variety of reasons. Sometimes it's trouble falling asleep, sometimes it's getting up, sometimes it's stress, sometimes it's our partner. Yes, we hear that one too. But we also have an increase in sleep apnea, an increase in restless leg. So I would really strongly encourage working on sleep. Sleep can be a long time care plan. So it's managing sleep hygiene. Sometimes it's managing your partner. Sometimes it's being screened for sleep apnea. So maybe you need a sleep study. Sometimes you can do your own little sleep study with a home wearable. But optimizing sleep, that can also mean not alcohol before you go to bed, because alcohol before bedtime actually interferes with our sleep. So sleep environment, what you eat, what you drink before you go to bed are all key factors to sleep. And then screening for other sleep disorders that have treatments. So hormones, exercise, nutrition, sleep, stress. So stress management is super important to weight management. Stressful eating is not good. Stress also actually increases cortisol. Cortisol, if anyone's in the medical community, everyone knows that cortisol and cortisone and hormone shots make you gain weight. So cortisol, it also drives you to do stress eating. So stress management is actually a very good component to help you with weight management. And then the last pillar is medication assisted, supplement assisted, or surgery assisted, right? So we've looked at surgery for people whose BMI is above 40. So that's generally the morbidly obese, which translates into being, definitely over 100 pounds overweight. Even now in that group, though, they're starting with medications as well. So I won't talk as much about surgery, but we can do medications, we can do supplements. We discussed the medications already, the GLP-1s, because that's been all the news and what everybody's asking about. There are older medications that can help as well. I mentioned metformin. There's also a drug commonly used called Contrave. Contrave actually helps impulse control. And if you're an impulsive eater or a reflex eater, that can actually help. It's generally associated with less weight loss than the injectable GLP-1. So you're going to see more on the order of like 5% of your body weight loss over 6 months, whereas the GLP-1s can be up to 20%. So 16 to 20% depending on the medication. So we have that. And then there's supplements as well. So there's a supplement, berberine, we use that has been associated with up to 5 to 10 pound weight loss over 12 weeks. There's other supplements like ashwagandha and lemon balm that actually can help with stress management. And then, as I mentioned before, stress management can then in turn help with weight management. And then 5-HTP has always been given in weight clinics. And that can actually help you sleep. It actually affects our GABA receptors and actually helps calm. So it depends on sort of what's contributing to your weight management struggles. So I really think a strong weight management plan involves many of these components. And at Midi, we invoke all of these components to help you with weight management. Other common questions, trying to think. How do I get the medications? I can't find them. So as I mentioned earlier, we at Midi help you with prescribing the right medications when needed. We also help you with the other pillars of weight loss, or weight management, I should say. We don't manufacture the drug, so we can help you. We can help you and share what we know about medication access. There are compounding pharmacies that are making the drugs that are of similar compounds. So they make a semaglutide, for example. They combine it with vitamin B12, so it's not exactly the same as Ozempic and Wegovy, but can have similar effects. They are having less of an access issue. In general, compounded drugs are not covered by insurance, so these are usually cash pay options, and they can cost around anywhere from $200 to $300 usually a month cash pay. If you are looking at doing a compounded option because either you don't have insurance coverage or there is a manufacturing shortage, they do make similar compounds in the compounding pharmacies, and they can be accessible. You still need a prescription, which we can help you with if these are the cases, and they are cash pay. So, and they're also, it varies state by state because there's different state regulations on compounding. All right, let me see what other questions we have. I've heard about the terrible side effects and why do they happen? Okay, so I presume this is around the GLP-1s. So with the GLP-1s, they actually tell our brain that we're really full. So imagine you had a Thanksgiving dinner. It basically binds to the receptor and tells you you're really full. If you start on a really high dose, it will tell you you're so full that you will actually you'll have nausea, and some persons even will vomit, right? So that is one of the reasons we started a low dose and escalate up. When you start at a low dose and escalate up, the side effect is less. The other mechanism of action, so it tells our brain cells that we're full, but it also slows down our gut. And slowing down our gut makes us feel full longer. So when we eat a little bit, it actually helps us feel full longer. When you slow down the gut, however, you can get more stomach upset. You can get more reflux, heartburn. You can get burping. You can get constipation. So that's probably the most common side effects are a little bit of GI upset, which for most people is a little bit of constipation and sort of slow gut motility. The side effects are largely manageable. One, through starting slowly and titrating up slowly, and two, through some basic tips like drinking a ton of water. You need to drink a lot of water. You may need to increase your fiber. You may need to do some laxatives that help you with constipation. So at Midi, when we start people on medications, we generally want to see you in every month for the first few months until you get down to a rhythm and are on both a stable dose as well as able to manage any side effects. So by and large, the side effects are manageable. There are a couple significant side effects, though, that we need to be careful of. So gallstones and pancreatitis. So they're kind of connected. They're deep in our gut. They're organs that get upset at times. Right? Gallstones, people think of a stone obstructing a bile duct, and it causes a lot of problems. It causes inflammation, pain, fever, severe abdominal pain. Being obese, we're at risk factor for gallstones. Losing weight, for whatever reason, puts you at risk for gallstones. It's thought because we are actually using the bile duct less, so you can actually get more gallstones when you're losing weight. There's some studies that say these medications, in addition, give you a third risk for gallstones. Other studies say that it doesn't increase the risk, it's just because you're losing weight, so it's really the same risk. Regardless, we all need to know about gallstones and pancreatitis. So upset like constipation, burping, heartburn is normal and can be managed. If you're starting to actually get pain, so severe pain, then we'd want to check you to make sure you're not getting pancreatitis, which is an inflamed pancreas, or gallstones. You can do that with the lab. Often you need to go to an urgent care center to actually have someone feel your belly and take your labs urgently. And then we would have you come off the medications and obviously deal with the gallstones. These are rare events. I actually haven't had anyone have that happen yet at Midi, but they do happen, and there are good things for us to be aware of when we go on the medications. The other side effect to be aware of is if you have diabetes. So for persons with diabetes, they should be getting regular eye checks because you can get a thing called retinopathy where you basically kind of plug the vessels to your eyes. So if you have diabetes, I would want you to get an eye check before you started a GLP-1 because it can flare up the inflammation there temporarily, and you can get blurry vision that then gets better over time, but still it's better to actually have your retinopathy treated before you would start a GLP-1. Anybody with diabetes should be getting regular eye checks anyway, so it's an important part of maintaining your health. So it's just more about sequencing what you do there. Let's see, what other? Have you experienced persons who don't lose weight for the first few months, even though they're eating and exercising? Absolutely. I hear that all the time because, like I was saying, in midlife, a lot changes. Our metabolism slows down with age first. So everyone said, I'm doing the exact same things I've been doing for 10 years, yet I'm gaining weight. That's a very common story. We also have a worsening of insulin sensitivity, and our liver metabolism of food changes. That's why our cholesterol goes up. So we do need to modify our diet and exercise program in midlife to adjust for the changes that are happening from within. So I think if you're adjusting and doing the exercise and dieting, that's awesome. I think if you're not getting a response, it's good to get screened for thyroid disease. About 6% of women will get thyroid disease. That can and actually that incidence increases with midlife and beyond, so it's good to get screened for that. I think there's some supplements that can help. As I mentioned before, I would look at sort of our 6 pillars, right? So would hormones help? Would more exercise help? Like look at what the regimen is. Look at nutrition. Sometimes it's not what you eat, sometimes it's when you eat. So timed eating has actually been shown to be efficacious in midlife. It sort of exercises and improves your insulin sensitivity. Sleep, stress, and then medications or supplements. So you can look at all of those things. So lots you can do to actually help. But I do agree, and it's a common story, that in midlife, weight becomes a bigger challenge. And with those challenges, we do some adjustments and stay healthy. Can you speak to the psychological effects of some of these medications? That is a great question. Well, first of all, there's a massive psychological effect to self-image and body image when persons gain weight. And actually there's lots, it's a whole other conversation to talk about the biases that all persons experience who actually have obesity. So there's a lot of psychological effects just from gaining weight on image as well as obesity. That some of it is institutionalized, some of it's cultural, and some of it is our own self-image. So actually feeling empowered to actually lose weight can be helpful. I have had many, many women say that because you feel satiated, you actually feel satiated with the medications, that it takes away the food noise. You'll hear that. Like I've had a woman tell me that for the first time in her entire adult life, she was able to think about something other than food, and she felt like the whole world had opened up, right? So she's thinking about travel and going to do things and isn't always thinking about the food she is or is not eating. So, because so much of her mind had been about dieting as an adult, and so much of our identity was wrapped in it. So it can have positive psychological effects. It was a very small study that showed in a small number, and it was the N, I think, was 20, where there was depression and suicidal thoughts. But I want to say that there have been there's been no prospective study looking at it. Those were anecdotal reports. There are tens, actually hundreds of thousands now of persons that have had these medications. So it hasn't been seen and studied in a way that I could actually give you stats or trends. I would say if you're responding in that way to the medications, I would talk to your provider, and we can seek other ways to support you in weight management. So I think the jury's still out on some of it. The other thing that has been studied a bit is how it improves impulse control. So what we've noticed, and I have definitely had many patients tell me that in the way it gives you satiety for food, it actually decreases your desire for alcohol. So there was a small trial in Europe that looked at it specifically. It was very small. It was under 100 people. They had noticed the effect in persons on it for weight. So they did a small pilot and did a placebo-controlled, and actually it did significantly decrease alcohol ingestion. And I definitely have patients tell me that they no longer have a taste for alcohol. Which is actually a good health benefit. So they like it, actually. And now it's being studied in also gambling and other sort of impulsive disorders. So there's nothing definitive on this. I think if you're seeking these medications to help you with these, I would do it in the guise of a trial, and there are trials looking at this. Okay, do antidepressants help when in perimenopause or menopause? Is hormone replacement therapy enough to support the feelings of sadness? So we know that as our estrogen depletes, that a lot of our other brain hormones adjust. So we know estrogen depletes our other brain hormones like serotonin decreases, as well as dopamine. So we actually have triggers in our brain that are triggering some of this, what people label as moodiness, or feelings of sadness, or difficulty sleeping, right? So our serotonin decreases, we know that affects sleep. And if you look at our antidepressants, they are SSRIs, right? Serotonin reuptake inhibitors, which are actually increasing serotonin activity. So these are the same hormones that our antidepressants are actually working on to actually help us feel better. We also know that we experience hot flashes and night sweats. Hot flashes and night sweats they don't come from our ovaries or our breasts, right? It's coming from our brain, from the thermal regulators in our brain. So SSRIs have actually been shown to actually help with hot flashes and night sweats, which then can help sleep, which then can help weight management. So I think the question really is talking about how it's all related, right? So our hormones decrease, our other hormones then reflexively decrease, and we have a lot of changes. We need to adjust our lifestyle to support the health that we want and what our health goals are. But SSRIs and some antidepressants can be effective for multiple symptoms of menopause. And some have been associated with weight gain and some have been associated with weight loss because of the way their mechanism of action. So it sort of depends on the antidepressant, quite frankly. Do the different drugs have very different efficacies? Yes. So I would say very different. If you're looking at GLP-1s, the range is from anywhere from 16% weight loss to 21% weight loss, which is an immense amount of weight loss. What I tell persons, though, is they're very expensive and they're hard to find with manufacturing shortages. So I try to not have you get your heart set on one because they're massively efficacious, all of them. So the one you can get your hands on is actually a good one. And they're all very efficacious. There are slight nuances. Tirzepatide has the 21% efficacy, so often people want to seek this one. But if you can't afford it and it's not on your insurance formulary, then I love semaglutide. It also works very, very well. And not everybody needs to lose 21% of their body weight. For some, 16% is just fine. If you're looking at the other medications, more like the metformin or Contrave, you're looking more in the sort of 5% of your total body weight. So if you're, that's lower amounts of weight loss. And then supplements generally are in the lower percentage of your weight loss category as well. I love someone talking here. She's doing all these pillars except the stress component. Well, you are not alone. Midlife is stressful. A lot of times it's when we have responsible jobs with increasing responsibilities. We have aging parents. Some of us have, teenagers that are a little stressful as well. Not that that's always the case. But we definitely see high stress levels in midlife. And remember, we actually have changes to our GABA receptors, dopamine, serotonin. So our ability to manage stress is actually harder as well. So we have to be more purposeful about it, which may be taking, accountability for our diet, really focusing on sleep, and doing things. If a question, can you take metformin and berberine together? You can. Berberine does have some drug interactions, but it's okay with metformin. Lots of questions. Is the Ozempic face real and what causes it? The Ozempic face is probably related mostly to the weight loss. You're losing weight in your face. So you get about 6% weight loss in the first 3 months. That's the other thing. I want to say that usually in the first month you start these medications, you don't magically drop off weight. I had people come in November that wanted to be, 40 pounds lighter by Christmas. Doesn't happen that fast. Largely because we're titrating up on the medications. Remember, we start at a low dose and we go up the second month so that you can tolerate it on side effects. So you're not going to lose weight in that first month for the most part. Generally, we start to see the weight loss in the second and third month you're on it, and then it should be slow. You don't want to lose weight that rapidly. As I talked about before, the more rapidly you lose weight, the more of it is muscle, which is not what you're trying to lose. So you want to have 1 to 2 pound weight loss per week. And generally, we stop titrating up once you hit that level. So it does take a little while. And the Ozempic face is often about weight loss here. I don't know of ways to prevent it. I think people are looking at that. In general, though, I would try to make sure your weight loss is at a reasonable pace and not try to do it in 2 months, because the faster you lose weight, the more of it's muscle, which is not what you want to lose, right? Here's a good question. She was on progesterone and a GLP-1 for 4 months and did not lose weight. So one, I would want to look at the dosing on your GLP-1 and then which GLP-1. Sometimes if you weren't on the tirzepatide, that's a person I would petition heavily with their insurance company to try and get them on a tirzepatide, which has the higher efficacy. The other thing is if you're starting out at a much higher weight, I think you start to lose weight later. You need the higher doses because there is a bigger volume of distribution of the drug. So I would have to know sort of what your underlying, what you were receiving and how much it was titrated up. Did you go to the max dose and what brand you were on as well? But the second question is interesting is, did progesterone cause you to not lose weight? I would say probably not. Now there actually have been a lot of trials about, does hormone replacement therapy make me lose weight or does it make me gain weight? Putting all the trials together, it does neither. You can acutely get some breast engorgement from water retention and things from estrogen. Some women like that actually. And that's dose dependent, and usually we're giving you low enough doses that with hormone replacement therapy, that's less of an issue than it is with birth control pills, which have higher doses of hormones. So by and large, if you look globally, it doesn't really make you gain or lose weight. It does help you not gain weight centrally, which is actually important because I mentioned central weight gain is bad for your health. So I would more look at what you were doing with the GLP-1 and see if we could do something to optimize that than looking at the progesterone. Why does weight loss stall on these drugs? Some attendees are saying that the drugs never worked. So remember now, for weight loss alone as the indication, what we've seen is if you stay on the drugs, for the most part, most people keep it off. What we also see is that most people stop the drugs. So 75% of people will stop the drugs on their own, not at the direction of their doctor. They just like, I've reached my weight, I'm done. There is what we call a hangover effect where you still keep the weight off for a little bit. But then most people will gain the weight back if they stay off it long enough. Not everyone though. About a quarter of people sort of keep the weight off. What's happened is the relationship with food and the regimen that it's supported during the period on the meds actually is sustainable for them. So I actually have one patient who's been off for 2 years and kept her 75 pounds off. She's a very regimented person, but the relationship changed and then she was able to sustain that. But for 3/4 of people, once they're off drugs, they gain half to 2/3 of their weight back. So there's still success in those persons where some of the weight stays off. But right now, when we prescribe the drug, we don't know if you can come off, right? So it's the way these were studied was that they stayed on them indefinitely. The NIH is doing a trial to see how we can help people. What's the best way to get people to keep the weight off? So right now we have people starting. When you reach your goal weight, we titrate you down a bit. And then we commit to staying up on what the NIH trials show. And I mean, there's new studies coming out on these drugs every day on how to get people off. I think there's lots of interest in that. There's lots of studies in that. And we have to see as you go. That was a little bit indirect in your question, which was why they didn't work or stopped working. I think it's a multitude of reasons. I would like to know which drug they're taking. For some, right, if you take the one that's daily and not the one that's weekly, we see a lot of people skipping days or skipping doses because maybe they want to enjoy dinner and they want to have, time off. So I'd want to look at adherence. I'd want to look and make sure that you were administering it correctly. I'd want to see which the drug was because some drugs are more efficacious than others. So make sure you're on an optimized dose. And by and large, they say it's about 86% of people respond. I would say in that 15% is probably at least half of them are people that don't tolerate it due to side effects that we end up stopping. And it's a very small percent that don't respond at all. Very small. How to maintain muscle mass on the drugs. Well, that's going to be a little bit of hard work. It's my biggest challenge. I actually share on my vlog with Midi that it's finding the time to exercise regularly, but some component of exercise, it doesn't need to be anything extreme. It can be vigorous walking, but you need to use your muscles. We like weight-based exercise woven in, but you need to actually, I say the exercise that you enjoy because you will do it regularly is actually what you need to do. Do you still enjoy food on these medications? That's a really good question. I'm going to be honest. I have had one patient who was in the BMI was 30 and actually qualified for the meds and was losing weight, but actually wasn't enjoying wine in the way she used to. and she liked a wine pairing with food, so actually stopped. And that was these choices are very individualized, right? So we have her on a different weight management program. I will say for the most part, when you start the medications, the first week, I think it tells your GL receptors you're full, so you're not hungry, so you don't have that hunger and then that feeling of satiety surge after you eat. But you can actually enjoy the taste. It doesn't affect the taste of your food. It affects the desire for food more. So most people are still enjoying their food. I would say I hear different things on alcohol. Many of the patients say they just don't have the taste for alcohol and they can't do alcohol. So I think the jury's still out on what it's going to do with that. I think people are excited about it making people drink less because in general it's not the best thing for our health. How do you prevent losing too much muscle? So I would aim for a dose of medication that you're not losing it too quickly. I think a pound a week is already pretty aggressive, and that's where you're going to already be seeing up to 20% of your weight loss be muscle. So if you don't aim to lose it that fast, and incorporate a regular exercise regimen while you're doing this. This is not just about taking medications and not having to do anything else. Someone mentioned Ozempic face is because we're getting older. Well, that is true, actually. So we know we have a decrease in collagen production. Actually, menopause decreases our collagen production in our skin. So for women, it's compounded more than even for men. No pun intended on compounding there. But so we definitely don't have sort of the skin turgor or elasticity we used to when we're young. So when we lose weight, it will be prone to sort of looking more saggy. We do have other skin and hair treatment regimens that actually are evidence-based that can help you with sort of collagen in your skin. Some topical estrogen helps. A little bit of hormone therapy actually helps maintain skin turgor. So tackle that separately. Can the nurse practitioners at Midi help with these medications during your appointments? 100% yes, absolutely. The medications are new, so we have spent a lot of time in the last year staying up to speed on the best evidence and best use of these, best patterns. So we have spent the last 6 months making sure every single one of our practitioners is ready, educated, and experienced in using these. And then we have weight experts that help them before and after the visits, and we're here for complex cases as well. So every single one of our Midi practitioners can help you with weight. What are the don'ts when on these prescriptions, right? Don't think the prescription is everything. I think I would engage in them when you're on a journey for weight management. So be committed, right? So if the medications are an expensive resource. Coming to the visits and a resource. So it's really a time to lean into nutrition. You cannot take these medications and then have them take away your appetite and then choose to eat popcorn for dinner. It's not good for your health. So you have to be prepared to lean into sort of a healthy, nutritious diet that's balanced with protein, nutrition, fiber. And you have to be prepared also to exercise a bit so you can combat muscle loss. So I would say those are the two. You can't, the big no is just thinking the medications is all you have to do, and you actually have to be committed sort of in a lifestyle kind of way. Other no's with the medications. I just temper your expectations, right? Again, this is not an overnight thing. This is not a magic that you get an injectable and then suddenly 2 months later you are there. The other thing is stay hooked in with healthcare, because I think 3/4 of people are stopping the medications and then experiencing rebound weight gain. I think we can do that in a much tempered way by reducing your doses, potentially getting you off, and then maybe monitoring, and then doing some titrations. There's also ways to step down potentially to metformin. So I would say stay linked with healthcare even after you achieve your weight loss that you're desired. Well, we started late. I thank you for coming. I am going to hop off, and if you have more questions, come to joinmidi.com, talk to your practitioner, and we'll be posting more of these live as well.